Welcome to this webinar to launch the Physiological Society and Centre for Ageing Better's new joint report. We've had a fantastic sign up to this event from a very diverse range of countries, specialisms and backgrounds, so welcome to you all. I'm Allison Giles, and until November this year, I was Associate Director for Healthy Ageing at the Centre for Ageing Better, and so I'm really delighted to be back chairing this event. I should just say that I'm having a few network issues today, so I may have to hand over to one of my colleagues if the issues continue to be a problem, but hopefully the network will hang in there. So we're joined today by four excellent speakers. We have Professor Paul Greenhof, Allison, Sudhuhurst and Beth Mitchell. And between them, they're going to talk us through how COVID has affected the health of older adults in this country and what steps are being taken nationally, regionally and locally in England to address the negative changes that we're seeing and the change in habits that have occurred as a result of both the infection itself, but also the related lockdowns and mitigation actions that have been taken. So just some housekeeping before we start. We're recording the event for those unable to join us today, and the recording will be available at the same web link as the report. You will all be in listen-only mode as attendees, but if you have questions for the panel, please do post them using the Q&A box, which you'll find in the control ribbon either at the top or bottom of your Zoom screen. By way of background, the Physiological Society and the Centre for Ageing Better published a joint report in November last year, which examined the impact that the pandemic and resultant lockdowns were having on older adults' physical and mental health. And the report we published back then included findings from a YouGov poll of older adults, and the report also set out recommendations for a national post-pandemic resilience programme, which we wanted to see put in place to support older adults to re-engage in activities that they enjoy and also to build their resilience to future events. And sadly, at the anniversary of that report here today, we find that we're still very much in the eye of the storm and that the report that we published last year is just as relevant today as it was a year ago, with the need to be thinking to the future and how as a nation we can help our older adults to recover their health and boost their resilience as and when life does return to some semblance of normality. So what we've done and what we're launching today is we've brought last year's report up to date with some new survey findings on how older adults' activities remain impacted by the pandemic. So if I could have the next slide, please, Tom. What we found in the new survey is that 26% of all over 50s reported doing less or much less exercise than pre-pandemic. And this was particularly acute in the over 75, so a cohort that we're particularly worried about. We saw differences between the genders for why this was, with women more likely to report a lack of motivation and men more likely to report a loss of habit of exercise or of socialising in person. And we also saw differences among different age groups in response to the question about what might help them re-engage in activity. And so what we saw was the younger age group preferring tools like activity monitors to sort of help motivate them to be active. And the sort of middle age group expressing an interest in the social aspects of physical activity and group exercise, which is something we know has been particularly impacted by the mitigation actions that have been put in place. And then what we saw amongst the oldest age group, so the over 75s, was a preference for tailored advice from a healthcare professional. So we saw a real mix of need and preferences really in terms of what we need to do to support people to re-engage in activity. Can I have the next slide, please, Tom? So our report calls for the Office for Health Improvement and Disparities and public health agencies across the UK to launch a national post-pandemic resilience programme. How we envisage this is as a joined up system of support to provide older people with tailored advice and guidance on how to improve their health post-pandemic. And our aim is not only to return older adults to their pre-pandemic physical activity levels, but to encourage greater long-term levels of activity than they were doing previously, because it's so important for their health and well-being. Can I have the next slide, Tom? And in terms of the key ingredients that we'd like to see in this programme, we want a programme to sort of really increase physical resilience that focuses on older people, particularly with high risk factors that include obesity, type 2 diabetes, cardiovascular disease, and sarcopenia. And we'd also like a specific focus on increasing physical activity of people who are in their 50s. And that's with that sort of real idea of preventing future frailty and ensuring that people in midlife enter later life in as good physical condition as possible. And particularly relevant to the current context, we want the physical activity offer to include an at-home option or options, so that people who are nervous about being out and about, and particularly right now, have good ideas and guidance on what they can be doing at home. And thinking about people as a whole and their whole health and well-being, we want guidance about the importance of a healthy, balanced diet to complement information about physical activity, and to really try and embed steps to behaviour change, so to make this a programme that will really help ingrain future long-term habits. So with that context, it gives me great pleasure to introduce our first speaker this afternoon, who is Professor Paul Greenhof, who is one of the authors of our report. Paul is a member of the Division of Physiology, Pharmacology and Neuroscience at the University of Nottingham, and he's also Deputy Director of the Medical Research Council Arthritis Research UK Centre for Musculoskeletal Ageing Research. And last but not least, is an active member of the Arthritis Research UK Centre for Sport, Exercise and Osteoarthritis. He's published over 160 original scientific papers and numerous review articles and book chapters. So with all that wisdom and expertise behind him, Paul will be describing the physiological impacts of a reduction in physical activity among older adults. So over to you, Paul.
Thank you, Allison. Tom, could you have the next slide? Okay. So what I've tried to do here is to give a sort of snapshot of current thinking. So in the solid yellow line, going from 40-year-old to 80-year-old, you will see what most view as the aging process. So there's a decline in muscle mass with age, which is termed sarcopenia, and there's a metabolic health. So there's a development of insulin resistance and increased adiposity. And this is a continuum from the age of 40 to 80 and beyond. And we don't really know what the causative factors are here, but we do know it is happening. Superimposed upon this, I've shown you the effects of inactivity. So as an example being lockdown, here in the dotted line. So we see this loss of metabolic health and muscle mass and increased adiposity as we decrease physical activity levels. And indeed, a lot of this relationship in the solid line could be due to reducing physical activity levels with age. I've also shown what happens in individuals who have an acute illness. In the context of this meeting, it could be, they develop COVID. So inflammatory burden plus inactivity is enormous physiological stress. And what is worrying to clinicians and scientists is that the trajectory of recovery we don't really understand yet. And indeed, you may have seen the national press today about people 1 year after becoming ill still not really showing much in terms of functional recovery. So this resilience program report that is being published today needs to focus on trying to think about how science interacts between clinicians, physiologists, sports scientists, can help individuals recover during this period following inactivity and increased illness. Next slide, Tom, please. The impact of inactivity is shown, I think, beautifully in this slide, which is published in the literature. So this is a mid-thigh MRI image showing, you know, the thigh muscles and the subcutaneous fat and the bone in a 24-year-old. And you see here the body composition characteristics, so body mass, and fat-free mass. Fat-free mass is basically muscle, vital organs, and bone. Here you see a 66-year-old male of a similar weight, but you can see their body composition is quite different to the young person. And this individual is performing 12,000 steps per day, or 12,500 steps per day. So using the Tudor-Lock data of what represents a healthy step count, this would be seen to be highly active. And you can see, yes, muscle mass is lower and mass is greater, but there's still clearly well-defined skeletal muscle and no or little infiltration of muscle by lipid. Here you see a male, similar age, very similar body mass, but clearly their fat-free mass or their muscle mass is a heck of a lot lower than their age-matched counterpart, and their fat mass is much greater. And this has, on average, 3,000 steps per day. So clearly, being active and in positive energy balance is having a detrimental effect both upon adiposity, muscle mass, also not shown here, but also metabolic health. Next slide, Tom, please. As an extreme example, to make the same point, here you see a 40-year-old triathlete, same mid-thigh MRI, a 74-year-old sedentary person where clearly there's significant subcutaneous fat accumulation and atrophy of muscle. And here at the bottom, a 74-year-old triathlete. And I include this image just to show high levels of physical activity really can be protective. And it does beg the question of how much of the aging process is linked to inactivity, and secondary to that, what are the real negative physiological consequences of lockdown upon our muscle mass and metabolic health. Next slide, Tom. At that question, this is a classic now from Stephen Blair's lab, where he looked at nearly 4,000 men and nearly 13,000 women over a period of time. And they looked at all-cause mortality and the risk factors associated with all-cause mortality. And clearly you have the well-known ones like smoking, hypertension, diabetes. But what was very clear from these data and quite a surprise for the research field at the time was that low levels of fitness was seen to be a major driver for all-cause mortality, pointing to the fact that we do need to maintain our physical activity levels, particularly in older people who have lower levels during this period of reduced physical activity when we have restrictions. And we do really need, given where we are now, moving into our third year of the pandemic, we do need to introduce a mechanism to ensure rehabilitation of people, older people in lockdown. Thank you, and I'll hand back to Allison.
Thank you, Paul. Thank you very much for that. A very clear explanation of the science and very stark images there, I think, to sort of bring those facts home. We'll hold off questions until we've heard from all our speakers and move straight on to our next speaker, who is Allison Iliff. Allison is the Health and Wellbeing Programme Lead at the Office for Health Improvement and Disparities, Yorkshire and Humber Centre, where she has a focus on healthy ageing and dementia. And Allison's going to outline what the Office for Health Improvement and Disparities and other government departments are doing to address the reduction in physical activity amongst older people. So over to you, Ali.
Thanks, Alison. If you could move on to the next slide, please. Thank you. So I thought I'd start off by telling you who the Office for Health Improvement and Disparities is, because we're a relatively new directorate within the Department of Health and Social Care. We were established on the 1st of October this year, and we bring together the health improvement and health intelligence functions from Public Health England, which has since been disestablished, and from the Department of Health and Social Care itself. Our remit is to work across the health and care system, so both national government, local government, and at regional level with things like combined authorities and regional mayors, to focus on preventing ill health and reducing inequalities. On establishment, we've been given 5 key objectives. The first being to identify and address health disparities, but particularly focusing on those areas and those populations where health inequalities have the greatest effect. To take action on the biggest preventable risk factors for health, so tobacco, obesity, harmful use of alcohol and drugs. But I think we've seen from Paul's presentation, and it's increasingly recognised and spoken about that a lack of physical activity is as damaging as some of those other more recognised preventable risk factors. We also work with NHS and local government to improve access to preventative services and get people engaged in those as early as possible, to develop strong partnerships across government and with other stakeholders to act on the wider factors that contribute to people's health. So work, housing, education, and particularly, I think, again, for this audience, the environment in which we live. If we're wanting to encourage older adults to get out and be more physically active, we want the environment for them to be age friendly, for it to be safe, and an area that they feel that they can go out and contribute in without fear of either falling because pavements are poorly maintained or that there aren't pavements available for them, and that they feel safe and secure in their community. And then finally, we're looking to drive innovation in health improvement and looking to harness the best of technology, analytics and innovations in policy to deliver that change where it's needed most and reduce those inequalities. So in Public Health England, our predecessor organisation, and continuing in OHID, we publish physical activity data on our Fingertips platform. If you haven't visited that, I'd recommend having a look at that. It has a huge range of data across all different aspects of public health. The physical activity data, unfortunately, I think is relatively limited at the moment. I know there is work underway to widen the availability of that. At the moment, it's currently only published by all adults aged over 19, so it isn't broken down by age group. But that data is taken from Sport England's Active Life survey. They are official statistics, and they're derived from a survey which Sport England publishes twice a year that looks at adults' participation both in organised sport, but also routine physical activity like walking or cycling for travel to work, and also strength activity. And the portal that those statistics are published on, which is hyperlinked in the slides that you'll get later, is really useful, and it allows you to build your own report. So you can search by type of activity, by age group, geographical location, whether someone has a disability, different age bands, different time periods. So it's really sort of you're able to manipulate it to find the data that best supports what the argument you're trying to make, whether that might be to encourage additional funding for activities in your area to demonstrate the need for action to be taken in your area. So I really recommend having a look at that active lives data. Next slide, please, Tom. And that data was actually used by Public Health England when we published our wider impacts of COVID on physical activity in older adults report back in August. What we wanted to do was to model the impact that the lockdowns had in terms of reducing physical activity and what impact that would be having on the falls risks of older adults. So the charts that you can see on the right hand side are broken down by age bands from 65 to 69 up to 85 plus. And then each set of bars shows the amount of physical activity, the duration per week that individuals are taking. The maroon bars are from 2019, so pre the first lockdown, and the green bars were from the survey following the first lockdown. And what you'll notice is that in each age group, on the left-hand side of the chart, there is an increase. So that is an increase in the proportion of older adults who are doing the least exercise, only doing between 0 and 30 minutes of activity every week. And on the right-hand side, conversely, you see a reduction in the proportion of older adults who are doing the most activity, so more than 180 minutes per week. So across all age groups, there has been this shift towards lesser activity following the first lockdown in 2020. Now, we know that there's really strong evidence of the link between increasing activity and a reduction in the number of people who fall and the number of falls themselves. And so this report hypothesizes that the inverse relationship is also true, and that this reduction in physical activity is going to lead to an increase in falls. And it estimates that the reductions that were seen would lead to over 110,000 more older people having at least one fall per year. But we also know that a lot of older adults who fall have more than one fall per year. So the number of falls in themselves could increase by nearly 125,000 for men and 130,000 for females. And for each year that these lower levels of activity persist, the cost to the health and care system is estimated to be £211 million. And that's just as a result of related falls. But we all know that increased physical activity or maintaining physical activity has benefits much beyond the impact of falls. So whilst this can be modelled for this area, we can also expect that this will be having an impact on people's mental health and well-being, their cardiovascular fitness, their musculoskeletal health. So it's much, much broader than just falls. And next slide, please. The other thing that I should also have mentioned is that obviously that activity change was just from the survey following the first lockdown. As we know, we've had 2 further subsequent national lockdowns and a large part of 2020 with smaller areas of the country in higher restrictions. So the actual impact on older adults' physical activity levels are probably going to be higher, and therefore the impact on falls and other health conditions also probably going to be higher than the modelling suggests. So the report makes some recommendations for what we should be doing to address deconditioning across the system. It looks at whole population actions, so looking at promoting the awareness of the issue, making sure that people understand that this is a real need for older adults, that we need to build up their activity gradually and safely. It promotes the need for increased access to and promotion of strength and balance activities, and encourages us to talk about falls prevention activities and promote them in a positive way. So we all talk a lot about deconditioning, but actually perhaps we should be focusing on the reconditioning and the positive benefits of physical activity rather than always looking at the detriment that has come from not doing activity, but looking at that positive approach. And then it also recommends some more specific targeted measures, particularly for individuals who've had appreciable functional loss including specific rehab, physio services, and fall services. And if that deconditioning has been related to post-acute COVID syndrome or long COVID, also ensuring that people are referred to the emerging specialist long COVID rehab services. And in terms of what is actually already happening, the social care white paper that was published about 10 days ago announced that OHID will be managing a Deconditioning Inequalities Fund. So I think that's likely to kick off in the next financial year, and it will be looking to try and address the particular inequalities that we see in terms of deconditioning in older adults. And then on a regional basis, there have been a number of different activities in my region, in Yorkshire and Humber. We've established a falls and deconditioning network. Still in its infancy, we've had a couple of meetings, but really good engagement and focus on that. And we are looking at really promoting a regional falls awareness week next year, holding a regional conference. And we've also done some clinical audit work to identify where we need to make some improvements in our particular patch. My colleagues in the east of England have led a campaign over the last few months called the Deconditioning Games, again, encouraging older adults to be active. And then there's the Active at Home resource, which is, as Allison mentioned, with the current situation that we're in and a lot of older adults possibly feeling more anxious again about being outside and being in communities. The Active at Home resource, which is available on the Campaign Resources website, it gives instruction and guidance as to how to take activity safely at home if you are an older adult. And then lots of work going on at place, just a few examples there. One that I think is particularly important is around green activity delivery. We all know the benefits in terms of mental well-being for being in green and blue spaces. So providing people with the opportunity to do that activity in green and blue spaces will also benefit mental well-being as well as their physical activity and physical health. So that's it from me. Thank you. Back to you, Alison.
Thanks, Ali. That was a really helpful roundup of the work that OHID is leading. And it's really great to hear that you were successful in securing some funding through the Adult Social Care White Paper to support localities to tackle deconditioning and address inequalities. That's really excellent news. Our next speaker is Sudhuhurst from NHS England. Sue is Population Health Services Manager in the National Healthcare Public Health Team. So Sue used to be in Public Health England and moved across to NHS England when PHE was disbanded. So one of Sue's roles is to chair and coordinate the National Falls Prevention Coordination Group, which brings together experts from over 40 organisations and is currently focusing on ways to mitigate the wider impact of COVID-19 on reduced activity and deconditioning in older people, and is working more closely to tackle falls prevention across the 4 nations of the United Kingdom. So over to you, Sue.
Thank you, Alison. Good afternoon, everybody. Yes, so as Alison said, I'm in NHS England now in the Medical Directorate as part of the Healthcare Public Health team. Thank you. Next slide, please, Tom. So I'll just give a few details of falls risk factors, a little bit more detail about the National Falls Prevention Coordination Group, the resources that the group have produced and are producing, the 4 nations group, and how we're working together with the wider system. Thank you. Next slide, please. Thank you. So this slide is about falls in general, but it's actually a pre-pandemic picture of falls. And pre-pandemic, 30% of people aged 65 and over would fall at least once a year. For people over 80, it's estimated to be more like 50%. And falls are the #1 reason why older people are taken to hospital accident emergency departments. And in around 5% of cases, a falls leads to a fracture and hospitalisation, which is why it's really important to try and prevent falls and obviously to try and keep people more independent and give them better well-being. For people aged 60 plus, women are more likely to fall than men. So 29.1% of women and 23.5% of men had a fall in the previous 2 years. That was in 2016. Also, a lot of falls happen in the home, and unaddressed fall hazards in the home are estimated to cost the NHS in England around £435 million. So those figures, as I say, pre-pandemic, are likely to have increased for the reasons that Ali has just explained, that was brought out in the most recent report. So the risk factors for falls more generally, or if people have had a history of falls, they may have visual impairment, problems with eyesight, wearing glasses, cataracts. They may have environmental hazards, which may be external to their home as well as inside the home. They might be on medications that affect their balance, for example, and or they may have specific conditions like diabetes or Parkinson's disease and dementia, for example. But in this instance, we're talking about muscle weakness and deconditioning caused by the pandemic, which is clearly a risk for falls. Next slide, thank you. So the National Falls Prevention Coordination Group, or the NFPCG for short, was formed in 2016 and was in Public Health England, being led from, but there are now over 40 member organisations. NHS England is one, OHID is another, both from a regional and national level. So Ali is on the group, for example. Third sector charitable organisations like Care and Repair England, British Geriatric Society, Chartered Society of Physiotherapy, Centre for Ageing Better, that Allison was part of, and accidents and emergency colleagues in the ambulance service, for example, and fire service. So a huge range of people contributing to this group, and it's by working together and working in networks that we've been able to develop resources and take the work forward. So you may have come across the Falls and Fractures Consensus Statement and Resource Pack that was the first publication of the group back in 2017. Since then, particularly during the COVID pandemic, the group has worked together to produce resources, for example, for care homes, some details about how to get people up from a fall and try and reduce the pressure on ambulance services, they produced guidelines for commissioners to support commissioners in preparation for last winter and the winter that's coming up. And at the moment, there are 4 task and finish groups within the wider group that are concentrating on deconditioning, health inequalities, eye health or vision, and also making sure that we engage with public patients. So one of the groups I'll tell you a bit more about is the 4 Nations group, which has been formed this year, again by reaching out to others who are working on falls and fractures prevention in Wales, Scotland and Ireland, and bringing people together. We're just starting a group where we are going to have shared priorities and share good practice. So I've mentioned about resource development. So we're currently developing some messaging for public and patients, and also healthcare professionals and commissioners around deconditioning. And those are going to be ready in the new year, as well as resources that we're developing on vision or eye health to encourage more vision assessments, as vision is one of the key risk factors for people that to have falls. If you want to read more about the National Falls Prevention Group, we did publish a report earlier this year, which can be found on the .gov website, which summarises some of the work that I've mentioned. And one of the things that the Falls Group was involved with was the wider impacts report that Ali's described, and we were on the external advisory group for that, and are now involved in taking forward the recommendations from that report. One of the things that the group is also involved with very much is NICE guidance. So previously, when the NICE guidance on older people and falls was produced, members of the Falls Group were involved, and that's due to be reviewed in 2022, and people from the group are going to be on that committee going forward. Thank you. Next slide, please. So, as I mentioned, some of the resources that have been produced are listed there, and there are some links. So when you get the slides, you'll be able to look at those resources in more detail. There's also a return on investment tool that the group produced on falls back in 2018. And if you wanted to have more detail about setting up strength and balance exercise groups, there's some details about how that can be done to develop really good quality exercise classes, and how to improve current provision. Also, there's all our health as information generally available to the public about falls, and some e-learning was produced last year to help with initial training for people who aren't familiar with falls and fractures. Next slide, please. So the next slide is just, as I said, the Four Nations group that I mentioned was formed last January, and there's been 2 meetings since then. We've got a memorandum of understanding across the Four Nations to work together, and are about to finalise our strategy and key priorities across the Four Nations. So some of the work that's been done in Wales, for example, may be rolled out across England and other nations in the future. So we're trying to learn from each other and make sure that we're not duplicating work, and raising awareness of best practice. Thank you. And just lastly, just to highlight the fact that it's only by working together across the whole system that we can make change. And this includes in terms of deconditioning, making sure that any resources that we produce reach people from all backgrounds, particularly helping to reduce health inequalities. Yeah, healthy homes are a very important part of that. So looking at the wider determinants of health is really important in terms of keeping people physically active and independent and reducing falls. Thank you very much. I'll pass over to the next person. I think that's Beth. Thank you.
Thanks, Sue. Thank you for that very comprehensive overview of the National Falls Prevention Coordination Group. There's a huge amount of work going on there. Our final speaker is Beth Mitchell from Greater Sport. Beth is responsible for leading on the active older adults priority as part of Greater Sport's strategy. Her ongoing work involves collaborating with the Greater Manchester Ageing Hub and the wider ecosystem in Greater Manchester to make active ageing a central pillar within the Greater Manchester Ageing agenda. And Beth continues to support the established Greater Manchester age-friendly city region status, enabling better health, well-being and independence for older people. So Beth's going to describe some of the work that's going on in Greater Manchester to deliver physical activity programmes for older people. So over to you, Beth.
Brilliant, thanks Alison. So I'm the active aging lead at Greater Sport, which is the active partnership for Greater Manchester, which is one of 43 across the country, and our sole role essentially is to embed physical activity in sport across policy and practice across the life course, of which I focus on over 50s. Next slide please. So we work in collaboration, as Alison mentioned, with the GM Aging Hub, the Aging Ecosystem and national partners to embed the Greater Manchester Moving Strategy, which was refreshed earlier this year in September. And we have a key focus area around people, families and communities, of which healthy ageing is fully embedded within. And our mantra is creating the conditions to enable active lives for all, and tackling inequalities being at the core and centre of that. Next slide, please. So in terms of our work within active ageing across Greater Manchester, we're essentially created this framework where we are working to redesign current systems, create culture change, and to enable and create the conditions for active healthy ageing. And we're trying to obviously enable that nationally, but work to support that across Greater Manchester, making sure that all our work is led by localities and across local neighbourhoods. We've got 4 key pillars, of which are our key priority areas, being active travel and over 50s. I'll touch on the falls prevention work in more depth shortly. Adult social care transformation, so working to embed physical activity across adult social care. And work and health, so enabling active workplaces to support people over 50 to engage in activity. So in terms of our biggest focus in terms of reconditioning and supporting deconditioning throughout the pandemic, our main focus has been around the work on falls prevention, and we've been working really closely with the Healthy Ageing Research Group at the University of Manchester, Greater Manchester Health and Social Care Partnership, the Ageing Hub, and many other localities and key ageing leads across each of the 10 areas to look at how we sort of redevelop the existing pathway by bringing together a GM level falls collaborative, having mapped out the existing sort of community-based strength and balance pathways, the clinical pathways, and we have been working towards the launch of a GM falls report, bringing together all falls prevention work across the system to make sure we obviously respond to the deconditioning, but create an equitable pathway and system for Greater Manchester. And this has been a real strong effort across the system. Obviously, we already knew that falls was a massive issue in Greater Manchester pre-COVID, and obviously this has massively been exacerbated, and our response is really positive. Next slide, please. So I'm just going to touch on a couple of examples of existing campaigns which have been our Greater Manchester response in COVID. So we, Healthy Ageing Research Group again, created an evidence-based publication of the Keeping Well at Home booklet, which again was a real strong effort of the GM Aging ecosystem, and we were able to pull together to create a guide to support people to stay active and healthy at home throughout the lockdown, and it was a real added benefit in that we knew there was massive digital exclusion of older people, and we needed to provide support to people who were unable to access online resources. We were able to distribute that across each of the 10 boroughs, and we were able to also produce different versions in a multitude of languages to make sure we were reaching our communities. We also were able to produce Keeping Well this winter publication, which was an adapted version of key messages to support people throughout winter. And we were able to create videos and other resources, talking tips to support people within their roles and communities to be able to ask key questions to make sure we were supporting our communities. This is an ongoing piece of work, and there's looking at its lifelong approach and how we can support people who are deconditioned both at home and in the communities. So that's a piece of work that the Healthy Ageing Research Group are also leading on. So that's a whistle-stop tour of our approach in Greater Manchester. Thank you.
Thanks, Beth. Certainly was a whistle stop. You hope just draw breath. If all our speakers could turn their cameras back on, we do have about 15 minutes for questions, and the Q&A box has been very active. So without further ado, we will ask a few. So we had a question very specifically, I think, for Ali, which was about the Inequalities Fund that Ali mentioned. OHID will be leading the Deconditioning Inequalities Fund. I realise it's early days, Ali, but did you want to come back in and just comment on it?
Yes, yeah, unfortunately it is very early days. We say the white paper came out about 10 days ago, and there is an initial meeting next week to start talking about the relevant criteria that will be used to assess applications or to decide where the Inequalities Fund will be offered. What I can tell you is it's up to £3 million over 3 years. So it's not actually a significant amount when you think we want to try and test, we'll want to try and test some different approaches in different areas to try and understand what works. So projects will probably be relatively small, but what we're talking about in terms of criteria is weighing up things like, do we want to be looking at historical inequalities? Do we want to look at perhaps areas that were under lockdown or under additional restrictions for longest, so that the older adults in those areas may have been restricted in terms of their ability to be active for a longer time, and so there's an inequality there. Do we want to look at areas that have a higher proportion of older adults living in them? Do we want to include socioeconomic inequality? There's so many different criteria that we're going to have to discuss. But yes, first meeting next week, so early days. Hopefully there will be more information in the next quarter. And as I say, I'm expecting it will probably go live in the first quarter of 2022.
Great, thank you, Ali. Lots of work to do to get that out the door, I appreciate, but really great. I mean, like you say, it's not huge amounts of money, but I mean, it's a step in the right direction, so that's excellent. I've now gone and lost it. I had a question. Oh, so from Francis Ashcroft. Francis asked a couple of questions, but I thought it was very interesting. The MRI pictures are very dramatic, and although MRI scans aren't sort of routinely available, it's a question really about sort of how motivating it might be if people had a sort of better idea what was going on sort of before or after in their own muscle mass. I don't know, Paul, if anything has ever been used like that in research scenarios, has it?
You mean forming MRI to give feedback to volunteers?
Yes.
While they're in a study? No, I'm not aware of that. I would like to say, you know, we're concentrating on muscle here, well, the musculoskeletal system, but I fear that, you know, we're doing that because that's where the most measurements are available. You know, it is highly feasible, for example, that inactivity is having an effect on the brain, the cardiovascular system, certainly, you know, liver is also a likely candidate. And we don't have that level of granularity yet. And rather than focus on exercise interventions, I think there's a real need to start trying the physiological basis of inactivity. We do know, or it's emerging, the negative effects are extremely rapid. You know, there was a journal of physiology earlier this year showing within 24 hours of immobilization of an arm, there's a 50% reduction in insulin-stimulated glucose uptake. That is phenomenal. And it also begs the question of, you know, most of the targets that we're looking at that we claim are causing the dysregulation, are they really products of dysregulation rather than being causative? We need time course data to pull this apart. And we need to stop assuming that inactivity is just the opposite of exercise intervention. It's a silent physiological stress that we don't understand enough about.
Thanks, Paul. I had a question here, which I think I will ask Sue, which was about the evidence for the effects of exercise programs on falls, and whether we do have strong evidence or if it is a bit sort of mixed. I think you might have a view on that, Sue, the effectiveness of exercise programs.
Oh, hi, Ali. There is evidence for strength and balance exercise programs, but I'm not sure I'm the right person to be asking that. There are others on the call that may have that knowledge at their fingertips, but people like, Professor Dawn Skelton, for example, on the Falls group, has done a lot of work around the evidence of strength and balance exercise programs like Otago and FAME. So yeah, there is evidence out there, and if anybody wanted to contact me directly, I can point them in the right direction.
Thanks, Sue. Yeah, I mean, I think where some of the questioning comes in is the quality of the exercise program. I think that's what has probably impacted the results, isn't it? Because I think Otago and FAME are very clear and very sort of clearly laid out what the requirements are and are very directional. So, but yes, that's a great offer. So if you want to get in touch with Sue directly, please do. We've had various sort of questions about this causality, and I don't know, Paul, if you want to address this issue of sort of causality and reverse causality. I won't pretend to understand the ins and outs, and if it's too complicated for here, please say.
The causality is, here I'm specifically talking about the influence of inactivity on muscle metabolism. The causality has always been assumed to be, the two factors really. One is if you become inactive, the muscle no longer is contracting as much, and also your energy demand declines. So if your energy intake also doesn't decline, then you will store more lipid in muscle. And it's been thought that, there's this lipid spillover effect which induces metabolic decline in muscle. And there's also the lack of contraction will reduce the mitochondrial mass of muscle, which will also induce metabolic decline. But what is emerging is, within hours of, say, bed rest, muscle protein synthesis is falling. Insulin resistance is developing. So this is way too fast for what people thought were the prime drivers of the decline. So there is some signal from the lack of contraction driving these processes. So we're in the dark a bit about what this is. It isn't due to excess intake, because the change, increased adiposity and loss of muscle mass still occur when maintained in any balance for several weeks in bed. So it's fascinating. It really is. And I really do believe we're sort of looking in the wrong direction. Everyone doing exercise training studies to look at the, how we treat activity. We don't really understand how inactivity alters metabolism. And we don't even know, we don't know the effects on multiple organs in our body. There are now researchers looking, for example, at brain structure and how it relates to physical activity levels, which is fascinating. Sorry, that's a long-winded answer for something that there isn't a clear answer about, but it is what it is. It is an exciting area to be working in.
Thanks, Paul. I think this might be a question for Sue, because you did talk about care homes earlier in your presentation. So from Alec Tinker, how can we support care homes to increase residents' level of physical activity, ensuring that it's safe, but at the right level to be challenging enough? And I think this speaks to a question we had earlier from Kim as well about, you know, how do we get the right level of activity for it to be beneficial in improving strength and balance and muscle tone? So Sue, I don't know if that is one for you.
Well, I'll see if I can help with that one. On the National Falls group, we do have a number of people who represent care and residential homes. One of those teams is from the Enhanced Health and Care Homes team in NHS England. And they've been working with social care and care home providers to think about several things, and one of those is physical activity in falls. And I'm working closely with them, and we're looking at staff training, in particular in care homes, and how to help support staff, particularly new staff to care homes, think a bit more widely about how they can keep residents more physically active and help reduce falls. I mean, at this time when care homes are so under pressure and with difficulties of COVID, that's quite a difficult space at the moment, but that is currently being looked at, and so probably sort of later in next year we'll be able to sort of report back on how that's going.
Thanks, Sue. Beth or Ali, I don't know if you want to comment from your perspectives in Greater Manchester or Yorkshire and Humber about care homes specifically.
Yeah, I'm happy. I've actually just replied to Alec, because Alec's actually in Yorkshire and Humber, so I know him well.
Oh, great.
but actually it's something that we're very interested in. We had a meeting specifically around falls and care homes a few weeks ago, and the conference that the Falls and Deconditioning Network is planning for September time is going to focus exactly on that, and particularly we'll have a session on positive risk taking and how to encourage care home staff to allow their residents to move in a way that they may be worried about, but that will help their MSK health and well-being, and help reduce falls, because we know that risk aversion is something that is a real challenge, but I'm sure Beth will have lots of direct experience of that as well.
Thanks, Alison. Yeah, there's a lot happening in Greater Manchester to obviously pre-COVID to already look at integration of physical activity and strength and balance activities across Greater Manchester. We've got some really good pockets of best practice where there is a full physical activity and strength and balance programme. Care home providers are seeing the real benefit of that, but we do need to make sure that we've got the workforce development to underpin and make sure that it's evidence-based practice, so we are reducing falls and we are making sure that it's safe and going to see the results that we want to in terms of reducing falls and improving quality of life of residents.
Great, thank you. Well, I'm afraid we are out of time. I don't know how that hour whizzed by quite so fast, but thank you everyone for participating today. It has been a very lively and interesting Q&A and discussion. I'd like you to join me in thanking our 4 speakers, Paul, Ali, Sue and Beth. A key objective of our event today is to continue to bring physiologists together with public health professionals to help ensure that they're included as part of an evidence-led approach to public health. And I think it's been really insightful, actually, some of the questions that we've had today in terms of sort of how we inform our public health response. It's really interesting. It would be great to see more research involving older adults themselves so that we can understand firsthand what the impacts of declines in activity are, and also this issue of being inactive, so that we can design appropriate interventions. And I can't finish without encouraging you all to promote the findings of our report and to sign up to the report's aspirations. So thank you again, everybody. Enjoy the rest of your days and goodbye.